idea again, when you look into the population, it's like, no, if I put something that can extend the lumen, it's going to protect me. But yet again, the simple discussion is the elasticity of the vessel.
Correct.
And the integrity of the vessel.
That's one. The other
is
thing
compromised.
The other thing is putting a stent. Yes. If you're going to look at it as a PVC pipe or a getah, yes, it's going to be there forever. It'll be okay. This is a blood vessel. You put in, within 2 weeks, you won't be able to see the stent anymore. It will start covering up the intima layers. Everything will start to cover up. Now, the other thing is you will have like the entire saluran tu, you will have like a bump there.
Yep.
I mean, logical mind, simple. When there is a small resistance there, it will just cause another block. That's why there's another study. This is an international study which was done quite some time ago. It shows that 95% people who goes for the first stent will go for their second or third within 3 years.
This is without any lifestyle modification or with lifestyle modification?
General, this is a world statistic.
So technically, cardiology is not fixing the problem.
They're fixing the problem at that time, but
in an emergency position, yes.
Yes.
But in the long run, the data doesn't support that.
Correct.
The long run.
Correct. And not to blame them, but how many cardiologists actually sits with their patients and tell them you need to change your lifestyle, you need to change what you eat, and you have to exercise, you have to sleep well. No. They don't have the time. Of course, they are busy. Stent masuk pergi. A lot of my patients I've seen, they be like, I just stented, I don't know how it happens. They think that once you stent, okay, your problem is solved. No,
because
because
you see, their focus is always in that small, minute, particular location, but it's a systemic. And see, this is where the crisis will become really catastrophic.
Correct.
Because you have limited cardiologists. How many cardiologists we have in our country? 2,000, got lesser?
Around there lah. Yeah,
okay, 2,000 cardiologists for a 32 million population.
Yeah.
You do the maths for one cardiologist, and then you also understand that. Do you know that less than 20% of the country is having insurance?
Less than 20%.
And medical insurance is not even 8%. It's a huge gap to fill. So everybody is going to fall back to government facility.
Right.
And how many facilities you have? Even IJN is not even a government facility anymore. It's a privatized entity already.
Yes.
So you have like Serdang, you have like a satellite in certain regions. So kalau traffic ni meningkat, like I said,
waiting list
is one thing.
Yeah.
And you already have this doubling issue from 10,000 to 20,000. Another 10 years is going to move from 20 to 40 or even higher.
Yeah.
Because you have the morbid obesity, you have the lifestyle, the stress, the get-go punya lifestyle, the education of protecting ourselves is touch scope. Not just that, I'm going to add some more the cigarette, the vape, starting at a very young age.
Right.
It's destroying the endothelial lining of the
children,
of the vessels.
Kids,
So problem ni akan datang, and if alternative prevention, I mean, we're not just saying like everybody must sit on an E-ECP machine. Tapi we're going to look into that lifestyle issue, because the cardiologist is overboard to be on procedure. It's like for them, it's like I go in, it's like procedure. There's no time for me to sit and advise and sit down and have a 20 minutes chit-chat session with the patient. Takkan ada really. They're going to be even more busier. Unless we need to find like a 10 years, 20 years pipeline, okay, how to fix this gate of people. I mean, it's like people who are now in their 30s, how do they not get a heart attack in the 50s? They need to have that kind of agenda.
Correct.
That means you cannot fix this problem.
Yes.
And going to this kind of technologies, we know there's always resistance in adaptation. Big thing.
Yeah.
And also pushback by governance. It's a tough thing, because suddenly you cannot use, only cardiologists can use. You tak cukup cardiologist.
That's the thing.
You tak cukup cardiologist.
Bukan nak. I don't think they are going
because
to come
you see the problem with the medical industry is dollar and cents.
Right.
in our situation, no urologist want to sit down and just prescribe sildenafil or tadalafil. I would rather want to do a prostate biopsy or a prostate resection. It's 20 minutes for me in the surgery, and it's 20 minutes for me to talk to, for you to buy, for me to write a 100 ringgit prescription. Is economics of scale. They will not go.
Correct.
But what we need to now think is like, okay, how do we fix the problem or not create the problem to become worse?
Yeah, true. That's a very good angle of looking at it.
Yeah, because we will not fix the problem unless we get people to understand that, hey, you know what, we want to see what other countries are doing. Big countries like China, India, I'm pretty sure like Germany, Europe, all are using it. US are using it already. So
in US, E-ECP is covered by insurance.
See,
Medicare covers E-ECP since 1992. It does. In Germany also. And India, there's a practitioner, there's a cardiologist from India. He was talking about it the other day. One state of India have decided to actually, anyone above 60 or certain conditions, they can go and do E-ECP and it's paid for. The government pays for it.
they still want to keep the population higher.
I mean, they have, you see, like in India, it's not only for heart problems. Anyone who's more than 60, it's already an indication.
Okay.
But of course, that's not our indication. If you ask me, in Malaysia, it's simple. If you're 35 and above, you never exercise or you hardly exercise, you definitely need E-ECP.
Okay.
That is the thing.
Okay.
All right. And if you are quite active and all that, you know, you may not.
Okay.
Right.
Understand. So another question to ask, like, we know. I want to know who can use it, who can't use it.
Okay.
Because sometimes, like, if you mismanage something like this, it can even be catastrophic.
Correct.
Because, like,
Now, I would say any medical doctor can use it with proper training.
okay.
Now, this training is something that we can't get in Malaysia. Now, let's face it, it's not in our medical textbook. E-ECP was not there. But recently, it's already been added to Harrison's. In the last 3, this thing, yes, there is in Harrison's. Now, so a lot of doctors actually want to practice that, but they just don't know where to start, how to do it, and all that, because you have to go for a certain training. I went for my training in China and then went to India.
When was this?
This was 7 years ago, 7 years ago. And then I started this entire thing about 6 years ago. So, yes, so our group of doctors who is practicing E-ECP got trained by me, and then we did go to a few workshops in there was last one in Jakarta. It was Cardiology Congress.